Hello, I'm Dr. Shrestha. I'm a first year internal medicine resident in Mercy Hospital, Fort Smith. Along with Cynthia Inglis, Dr. Meg Bruce, Dr. Reddy, we conducted a navigation program for low-dose CT lung cancer screening implementation. As we know, lung cancer is the second most common cancer in the United States and is known to be the leading cause of cancer-related death worldwide. However, despite recommendation from experts for many years, the lung cancer screening has not been well adopted in practice. Survey data estimates that less than 5% of eligible patients receive LDCT screening. So even in our community, the rate of low-dose CT scan was very low. So in November 2021, we started a pilot program in our cancer center in collaboration with pulmonary medicine, where we identified two areas that needed attention. First was the need for shared decision making by the primary care physician before ordering the LDCT, and second was the need for follow-up of the patient with positive lung nodule. We assigned a separate individual as a lung nodule patient navigator exclusively for this initiative. Reports were obtained from EPIC every month to identify patients who fit the criteria. PCPs of the respective patients were then reminded to discuss LDCT in the upcoming visit. The long nodule navigator then followed the ordering and test results of the LDCT. All patients with positive long nodules were discussed in a dedicated long nodule conference. Follow-up interventions included referral to pulmonology, interventional radiology, or further imaging such as PET scan. Per guidelines, patients who did not need acute interventions were kept on track for their follow-up CT as recommended. Now let us review the results with our diagrams. So in a flow chart, we can see that total 749 patients were found to be eligible between January to June 2022, and they were expected to meet their primary care physician. From them, 574 patients ultimately got screened with LDCT, out of which 436 had the LDCT for the first time and remaining had follow-up LDCT. And out of these screened, 15 had findings which needed immediate intervention. Moving on to the second figure is a bar graph comparing our project in 2022 with previous baseline performance in 2021. The blue shaded portion denotes the LDCT screened, whereas the orange portion is the total eligible population. We can see from the graph that the LDCT referrals were quite high, as much as doubled with our navigation program in 2022 compared to prior year. Now let's move forward to discussion. LDCT carries certain risks like false positive results and unnecessary biases. Hence, shared decision making is needed before ordering the test. We identified the shared decision process as the rate limiting step across our institution, as after that point most patients decide to go for LDCT or not. So contacting and reminding the primary care physician directly through the navigator was a significant intervention that improved the screening. The second obstacle was the follow-up for positive LDCT, and we elevated it with the multidisciplinary long nodule conference. Therefore, this process is undoubtedly difficult to achieve without a long nodule navigator. Finally, each hospital system has its own protocol and may have various difficulties implementing screening guidelines. However, with this project, we can see that with the help of a long nodule navigator, we can achieve higher rates of lung cancer screening. And this is especially important in a demographic region with a high smoking prevalence like Arkansas, where active smoking is about 20% of the population compared to a national average of 16%. Thank you.